41 million Americans with commercial insurance just lost coverage for Wegovy. Another 109 million just lost their coverage for Zepbound. We are seeing major providers like Blue Cross Blue Shield of Massachusetts, Kaiser Permanente California, and CVS Caremark quietly pull the plug on standard weight loss plans heading into 2025 and 2026. This is the new baseline across the commercial market. And here's the catch. The drugs work exactly as advertised. Patients in trials consistently see a 15 to 20% drop in body weight. So if the medication is highly effective and there isn't a cheaper alternative hitting the market, why are the major insurers abandoning them? It comes down to a fatal flaw in the math of American healthcare. We are trying to squeeze a 30-year health benefit into a 3-year insurance business model. This chart shows total annual pharmacy spending for a major commercial insurer. This single 20% wedge represents GLP-1 medications from just 5 manufacturers. Broken down, claims data shows a cumulative cost of $11,200 per user over 2 years. Think of a power grid. If one new type of appliance suddenly draws 20% of your city's total electricity, and demand for that appliance is growing nearly 50% a year, the grid cannot support the load. To absorb that kind of concentrated, rapidly expanding expense, insurance companies have to raise premiums on every single person in the risk pool, including the millions of members who will never take the drug. Broad premium spikes are competitively disastrous. To protect their short-term financial survival, providers are choosing the only other option available to them. They stop subsidizing the medication. In health economics, there is a metric called the Quality Adjusted Life Year, or QALY. This chart shows the standard threshold for a cost-effective treatment sits between $100,000 and $150,000. Tirzepatide lands roughly at $197,000. Semaglutide reaches $467,000 per QALY. According to a recent JAMA Health Forum analysis, the probability of these drugs being cost-effective at current U.S. prices is exactly 0. Clinical data also shows that the vast majority of patients regain most of their weight within a year of stopping the injections. The treatment is an ongoing requirement, not a one-and-done cure. The insurance industry is looking at a permanent, lifetime financial annuity that wildly exceeds every established scale for cost-effective care. But these medications do deliver undeniable long-term clinical benefits. Over 20 to 30 years, patients see severe reductions in heart attacks, kidney failure, and diabetes complications. The problem is that the average American commercial insurance tenure only lasts 3 to 5 years. Members constantly churn between different employers and different health plans. Economists call this a positive externality. Insurer A pays $11,000 upfront today, but the financial savings of the avoided heart attack decades down the road are captured by Insurer B, or eventually Medicare. No single commercial insurer has a financial incentive to fund a patient's multi-decade preventative care when they know a competitor will ultimately reap the savings. It is a textbook condition for market failure. Now, to be fair to the medications, the drug itself isn't the root of the problem. The artificially inflated list prices in the U.S. healthcare system are doing the damage. The exact same dose of Wegovy that costs over $1,000 a month here runs about $300 a month in Denmark. If the United States implemented at-scale price negotiations like other developed nations do, the cost per QALY would drop straight into the acceptable range. There is also a glaring philosophical contradiction at play. The system readily covers pharmaceuticals for hypertension, but treats pharmaceutical obesity care as an elective luxury. The scientific breakthroughs are delivering real medical value. Our payment structure is just failing to capture and price that value correctly. But until domestic prices drop significantly or regulators penalize member churn, this coverage cliff is the new normal. If you're losing access, talk to your doctor about whether you qualify for a diabetes exception. You can also look into manufacturer patient assistance programs like Lilly Help or use HSA funds to help offset the out-of-pocket costs. And if you are considering cheaper compounded telehealth options, exercise extreme caution. Federal regulators have already issued multiple safety warnings regarding their varying quality. So where do we go from here? Should the U.S. force drug price negotiations like Denmark? Or do we need to completely restructure the insurance industry to handle multi-decade health benefits? Let us know your thoughts in the comments.